First, thank you so much for the introduction. It's a real pleasure for me to be here with you today. First time in Saudi, and a great pleasure to be here. Thank you again. Okay, very good. So this is the right slideshow. So first, these are my disclosures. I've been working with some companies in the business, especially with Mackay, which was a sponsor for this EOLIA trial. Also, I'm very grateful to all the PIs in the investigator of the trial group. There was centers in France, obviously, but also centers in the US and Canada, and also in Australia. It's been a great effort for all these centers. It took more than 5 years to randomize the patients in that trial, which ended up in the New England, if you remember, a couple months ago. What was the rationale for conducting these studies? There was a lot of advancements in the technology of ECMO, especially in the last 15 years with the new membrane oxygenators, closed circuits, centrifugal pumps. And of course, you all remember the successes of the H1N1 patients we treated almost 10 years ago now, and also the publication of the CESAR trial, which was suggesting some benefits, although the study was criticized for methodological limitations. And this is why, at that time, we designed a study which would be able to very early initiate ECMO in patients with severe ARDS, and to compare this outcome of these patients with those who would receive conventional mechanical ventilation with the latest guideline for treatment, especially including prone positioning, paralysis, and low volume, low pressure ventilation. So the trial was a multi-center international RCT using a sequential design. Randomization was stratified by center and by mechanical ventilation duration. It was also possible to randomize patients at non-ECMO centers. We had quite a few non-ECMO centers in France, especially in the Paris area. These centers had to be experts in the care of ARDS patients, and the mobile retrieval team had to be available to set up the VV ECMO machine within 2 hours following randomization in these patients, and then the patient was transported back to our hospital or to another ECMO center of the trial. Patients inclusion criteria were patients with severe ARDS plus one of these severity criteria. The first one was a PF ratio below 50 for more than 3 hours, despite the potential use of NO recruitment maneuvers and prone positioning. The second one was close, but was PF less than 80 for more than 6 hours, despite the same criteria. And the last one was respiratory acidosis with pH below 7.25 and a PaCO2 over 60, but not that just single fact, but this should have been the consequence of low compliance in these patients and the need to reduce the tidal, to reduce the minute ventilation because of very high respiratory pressure, and also despite the fact that the respiratory rate was set up to 35 before the patients could be included. Some exclusion criteria, people less than 18, massively obese patients, also patients with chronic respiratory insufficiency in need for oxygen, long-term oxygen therapy, patients in need of VA ECMO because of cardiac failure, and patients who were too sick to be included. So patients were randomized either to the ECMO group or the conventional treatment group. Patients randomized to the ECMO group got VV ECMO cannulation. Most of them got the femoral jugular setting very rapidly. We used a very low anticoagulation protocol in these patients with heparin targeting an APTT between 40 and 55 seconds, which is close to 1.2, 1.4 times the control. And we also use ultra protective mechanical ventilation setting with a PEEP over 10 and a plateau or high pressure limited to 24 centimeters of water. So the driving pressure, which is the difference between the plateau or the high pressure and the PEEP, was less than 14 on target in these patients. Control patient receive conventional mechanical for ARDS with a tidal volume limited at 6 milliliters per kilo predicted body weight in a PEEP to reach a P-plat of 28-30. Plateau pressure was limited to 30 centimeters of water in these patients, and was also a strong recommendation for the use of prolonged periods of prone positioning and also the use of polarizing agents. It was possible to use recruitment maneuvers, inhale, HENO, or prostasticline in these patients. We used the cardio from Mackay and together with Mackay Cannula for the trial. Very importantly here, is different from the previous trial, the Caesar trial, there was a rescue option, an ethical rescue option here for those patients who went very bad without ECMO, with those who develop refractory hypoxemia, defined as a blood oxygen saturation below 80% for more than 6 hours, despite mandatory use of prone positioning, recruitment maneuvers, and inhaled HENO or prostacyclin. The stats, we hypothesized that the mortality would be 60% in the control group, and we would observe 20% absolute reduction in mortality down to 40% in patients with ECMO, with an alpha of 5% and a beta of 20% using a group sequential analysis every 60 inclusion. So the results, as you remember, the study was stopped at the fourth interim at 240 patients 1 year ago, and because here, as you can see here, the cross went below what is called the Christmas tree. The Christmas tree is, if you remain inside the Christmas tree, this trial is continued. If you cross on top of the Christmas tree, you stop for efficacy. And if it's crossed below the Christmas tree, the probability of reaching the hypothesis which was originally defined in the study is very low. That's might be called stopping for futility, and this is what happened here for the trial. We randomized 149 patients. 124 were assigned to receive ECMO. Of these, 3 did not receive ECMO. 2 died very rapidly without any time, sufficient time to set up the ECMO machine, and 1 patient improved very rapidly and did not receive ECMO. 125 were assigned to conventional mechanical ventilation, and of these 35 were rescued by ECMO because of refractory hypoxemia. Patient characteristics, which is the same at randomization, was quite sick patients. You can see here mean SOFA score of close to 18 for 11. The median time from intubation to randomization was only 34 hours, very short treatment time. Here, the main cause of ERDS was pneumonia, bacterial pneumonia in 40% of the patients, and viral in close to 20. Another very important feature of that trial is the PF ratio, which was the lowest of any trial performed in ARDS so far. It was close to 70 in these patients, was not different between the 2 groups. Patients were ventilated with high PEEP, beat of 12, tidal was 6, respiratory rate at baseline was 30. The plateau was high, close to 30. The driving pressure also was high at 18. And based on the latest data, especially the paper from Marcelo Amado, showing that probably over 14 or 15 centimeters worth of driving pressure, the mortality increases significantly here. We are way above these threshold, and also the respiratory system compliance was decreased at 25. Importantly also, despite the very short time between intubation and randomization, close to 60% of the patients were prone before randomization, and virtually all of them were polarized at the time of randomization. So we applied ECMO. ECMO patients here now are in red, and control patients in blue lines and dots. So it was possible to decrease the intensity of mechanical ventilation with ECMO. From the tidal volume to 6 was decreased to around 3 ml per kilo. The PEEP was not different between the 2 groups, but the plateau pressure was significantly reduced, and the driving pressure also, as you can see here, was decreased on average to 13, which is a significant decrease from compared to the control group. ECMO is an artificial lung which provides decarboxylation and oxygenation of the blood, so it was possible to decrease the PaCO2, increase the pH, and increase also the blood oxygen saturation. As you can see here, was all significant as compared between ECMO and control patients. This is another very important point here. The way control patients were treated, prone positioning was applied to 90% of the patients in the control group, which is the highest rate so far, apart from the PROSIVA trial, which specifically tested prone positioning in ARDS patients. Was 66 in ECMO patients, but most of these patients actually received prone before randomization, and very few of them were prone after randomization. Once again, most patients were receiving NMBAs during the treatment. No difference between the two groups, but more patients in control group needed nitric oxide or recruitment maneuvers because of severe hypoxemia. No difference in corticosteroids, but it was mainly steroids for septic shock. 3/4 of the patients in EOLIA were receiving catecholamines when they were randomized, and more than 2/3 of them qualified for severe septic shock at the same time. So the primary endpoint of mortality was 35% in the ECMO group and 46 in control patients. Here you can see on the Kaplan-Meier curve that the hazard ratio is 0.70 with a p-value of 0.07, which is not statistically significantly different between the two groups. The 11% difference in mortality is close, but not statistically significantly different. We also defined a key secondary endpoint, which was deaths in ECMO group patients and deaths all crossover to ECMO in controls. This secondary endpoint occurred in 35% of the ECMO patients and 57 of controls, and this time the hazard ratio is 0.48 with a p-value which is below 0.001, a highly significant difference here between the two groups. Since we observed close to 30% of the control patients who did cross over to ECMO, we also worked with our biostatistician to try to compensate for this high rate of crossover. And there's some new stats which in a way can take this crossing over rate into account, and these stats are mainly developed by oncologists and hematologists for the trials. They use frequently, they have crossovers between the groups, and these stats are called the rank preserving structural failure time analysis, and using this model, the hazard ratio is 0.51, is very close here to statistical significance. The p-value is 0.055. Other endpoints, the patients were on ECMO for an average of 2 weeks. And this is another very important feature here of our trial. These are all the secondary endpoints which were tested here. And for each of these secondary endpoints, ECMO patients did better than control. They were requiring less vasopressors, and was highly significant. There was also less day with cardiac failure, less days with dialysis, less days of renal failure, less need for prone positioning or NO in ECMO patients as compared to the control patients. So there were some crossovers, as mentioned from the beginning. 35 patients of the 125 were crossed over. After a mean of 1 week, 6.5 days, these patients were sicker, clearly. And they were sicker from the beginning. They had higher plateau pressure, higher driving pressure, lower respiratory system compliance at the inclusion in the protocol. And they did very bad, especially within the last 6 to 8 hours before they were switched to ECMO. There was a steep increase here in the dose of inotropes, but there was a steep increase in here in lactate, and the PF ratio dropped down to 50 when the patient received VV ECMO. Before crossover, 9 of these 35 patients had cardiac arrest, 7 had severe right heart failure, and 11 developed acute kidney injury requiring dialysis. And more importantly, we had to apply VA, veno-arterial ECMO, in 7 patients because of severe cardiocirculatory failure, and 6 of these 7 were under CPR because of refractory hypoxemia when they got VA ECMO. So this is the outcome of all these patients. Here in the red bar, patients in the ECMO group, mortality 35. All patients in the control group, the mortality was 46. It went up to 57 for patients who did crossover. It was very high mortality. And even those who did not cross over and for whom the initial EOLIA severity was significantly less, and because all these patients here who crossed over were clearly sicker at the beginning, the mortality was still higher than in the ECMO group. There were some adverse events. ECMO is associated with thrombocytopenia, and actually there was some patients with thrombocytopenia in this trial. Some bleeding also leading to transfusion. We might also progress in the future. I do believe that we might decrease the rate of transfusion by applying a more strict transfusion threshold for these patients. And the most feared complications of ECMO, looking at the literature of the past, was brain hemorrhage and stroke. And actually we had a good surprise to see that this rate was lower in ECMO patients than it was in the control group. Probably because these patients received less dose of catecholamines and were clearly less sick during the course of the disease because they were rescued by ECMO. Some adverse events, bleeding, mainly minor bleeding at the cannula insertion site. Some infections also, and hemolysis occur in 5% of the patients. So this is the first conclusion I would like to present to you. This is the slide I presented at the ATS meeting in San Diego in last May. Concluding that there is no difference between the two groups. Of course, if you use the classical stats, which we'll call the frequentist stats, the p-value is strictly superior 0.05, so you need to say there is no difference, despite the fact that there is 11% absolute difference in mortality between the two groups, and despite the fact that close to 1/3 of the patients in the control group were switched to ECMO because they did very bad. But now I would like to discuss also with you why I do believe that this trial might be considered as a positive one. First, looking at the latest data in big ARDS cohorts and RCTs. These are the 2 RCTs conducted to test HFO, oscillate in OSCAR. Look here, PF ratio 120, 113, EOLIA 70. Mortality here in the control group, just the same that in our ECMO patients, 35. Here is even higher. And this is here the Brazilian trial, the heart trial, which actually presented at the same session at the ATS last May. PF close to 120, much higher than the PF of 70 we had in the EOLIA. Mortality was close to 50 as compared to 35 in our ECMO patients. We also did some sensitivity analysis with some hypotheses regarding the outcome of control patients switched to ECMO if they hadn't received ECMO. And if those patients would not have received ECMO, and making the hypothesis that up to 1/3 of these patients would have survived without ECMO, which is very unlikely, taking into account the severity of these patients whether they were switched. If 1/3 would have survived without ECMO, the study would still have been positive. And looking here at the rate of treatment failure we observed is very close to the first hypothesis we made when we designed the study. And actually, when looking at all the editorials and what was discussed after the publication of the paper, this is the editorial which was written by Jeff Drazen, which is the editor-in-chief of the New England, and he concluded his paper by saying that all the analysis all point to the same conclusion. ECMO probably has some benefit here, despite the fact that the trial not being traditionally positive. Drazen believes that the study is positive. And he also mentioned that most of the secondary outcomes also favor the ECMO group, which is true, and probably explain why the patient were better off. We also run a Bayesian model here to evaluate the true impact of the strategy here with ECMO. And the paper was published in JAMA a couple of weeks ago. And Bayesian stats are another way to interpret results of trials. Using Bayesian stats, you need to define what is your a priori belief of the efficacy of an intervention, here ECMO. We define here different types of hypotheses for the prior probability, strongly enthusiastic until strongly skeptical. And we also use data from the literature using a fully informative model or no informative model, and using meta-analysis data also making hypotheses about the efficacy of ECMO in patients with severe ARDS. Then we took EOLIA to calculate posterior probability of the trial being positive here. And you can read the paper. It's quite a little bit difficult to go through these sophisticated stats, but the conclusion was that the posterior probability of ECMO being helpful, ECMO saving lives in severe ARDS patients goes from 88 to 99%, depending on the prior hypothesis about the efficacy of ECMO, from highly skeptical to highly enthusiastic. And this is very impressive result here of this Bayesian model about the efficacy of VV. And actually, there was another editorial published with this JAMA paper. This one is from Derek Angus, who's the editor of the critical care section of JAMA. And Derek concluded that clinicians and researchers should no longer ask, does ECMO work? He's convinced that ECMO works. This question appears to be answered now. Instead, the key question should be by how much, in whom, at what cost. So we have to refine maybe a bit the indications, and also probably refine the way we treat these patients. There's a lot of work to do now on the treatment to improve the outcome of these patients we put on ECMO every day. We will have, in the coming weeks and months, data from the meta-analysis. I'm working with Giles Peak to conduct a meta-analysis of individual patient data from the CESAR trial together with our EOLIA trial. And this is my last slide, which is an invitation to Paris, also to our Congress in late June, in which we deal with all these issues. Thank you so much, and I will be happy to discuss and answer questions.